Okay. Now, a toxicity we haven't spoken of yet, infection. Especially the data looking that came from the CNS lymphoma with the combination of ibrutinib and steroids. Do you want to tell us more about that?
Yeah, so there was a signal. First of all of these targeted agents, I think we don't have a great understanding of how they inhibit the function of the immune system. And unfortunately, it's not simple like I'm going to check a CD4 count or an IgG level as a predictor of adverse events from opportunistic infections. There's been this ongoing history of these drugs, like for example, idelalisib had major issues with CMV reactivation and PCP pneumonia. Ibrutinib, particularly when given in combination for these heavily pretreated patients that you mentioned already, the CNS lymphoma patients, there was invasive aspergillosis, which was an issue. I think it's something you need to, and also PCP has been reported associated with ibrutinib. There was a blood paper from the NCI which talked about that as well. I think the standard of care right now is not to provide prophylaxis for these infections with a low threshold to do so if you feel that that patient may be at increased risk, keeping in mind that you can't really prophylax for invasive aspergillosis because there's a CYP3A4 interaction between most of the drugs that are out there, at least the ones that are oral, and ibrutinib. And so that is a major problem which is not easily overcome if you want patients to be outpatient and not having to come in for infusions for a very rare event. So I think we think probably these drugs inhibit more function than numbers, and that becomes hard to predict. So anytime somebody coughs or there's any reason to suspect something that could be opportunistic, we admit them, we bronch them, we biopsy, we look, because we do sometimes find these things.
Yeah, I recently ran into this in my own patient who showed up with both cold agglutinin disease, a warm antibody hemolytic anemia that with a hemoglobin of 4 required steroids with a white count of 200,000 from CLL and a Rye stage 3 disease, and needed steroids and ibrutinib, and quite challenging what to do there, especially in the area of the country where I'm practicing, where I've seen a lot of mold, aspergillus infection, especially in my acute leukemia patients. So not
there
a lot
I would prophylax. Well, for mold, I think you don't think you can, but at least with the steroids, I would prophylax for PCP.
How about, well, we've talked about ibrutinib. How about acalabrutinib? How does it compare? You mentioned something about that earlier.
I think the AEs are similar, but maybe less. We don't know for sure yet. I think that many people in the community are hesitant to speculate that they're less, especially given the fact that we have head-to-head data that will come out in the next year or two. It's just hard to judge one drug versus another. I feel like you do one or the other a disservice by making that comparison. So I tell patients, what the AEs were in the individual trials, but I oftentimes don't get into, putting the two tables next to one another and saying, hey, we're getting less AFib, we're getting this. Fortunately, the company who makes acalabrutinib and zanubrutinib were courageous enough to challenge ibrutinib head-to-head, so we will have those data, sometime.
Okay. So how about in CLL, we know that these patients are at higher risk of epithelial carcinomas, skin cancers. I know personally I often send my patients to a dermatologist one or twice a year for surveillance. With the BTK inhibitors, is there any special signal for an increased risk of those carcinomas?
I don't think so. I think that the best data that we have are the randomized trials. So, we have ibrutinib versus antibody, we have ibrutinib versus chlorambucil, we have ibrutinib versus FCR. We have, there's been several randomized trials conducted. I haven't seen a strong signal of secondary malignancy favoring the ibrutinib arm or transformation favoring the ibrutinib or the BTK arm. So I think everybody has these anecdotal stories of these drugs that we start on their 7th line of therapy and then they transform. But when you look at apples to apples comparisons across randomized trials, that doesn't really bear out as much.
And how about we know with FCR, fludarabine, Cytoxan-based regimens, higher risk of
marrow failure,
MDS. Have we seen that with
I don't
the BTK
think I've
inhibitors?
seen a signal. If it exists, I haven't seen the signal that suggests that it's causing those types of secondary malignancies.